And I'm going to ask Lisa Henning to start collecting questions for us. And please, in the audience, I know there's quite a few out there, go ahead and text. In the meantime, whilst questions are coming in, I'm actually quite happy also to announce that Dr. Florian Neuer, also from Heidelberg Institute of Global Health, is also here on the panel. And perhaps, Lisa, if you agree, I know you know each other, that if perhaps we draw into his vast and extensive knowledge with the questions. Unless you wanted to say anything else to add, Lisa, because I think the questions are still coming in at the moment.
I'd be delighted, Florian, I'd be delighted to hear from you and to have a discussion until such time as the questions come in. I think there's such fundamental questions that the COVID vaccines disparities raise, particularly about the way that we address global health challenges. And some of the debates that we have. I came up as a doctoral researcher working on HIV medicines, and looking specifically at the way in which global health approached these, and also the way in which human rights were or were not interacting with trade laws. And I remember that a lot of the debates in global health at that stage were very much focused on very sort of dichotomous arguments. We can't have access to HIV treatments in low and middle income countries because we need to focus on prevention rather than treatment. I don't know if you all remember the debates over, should it be prevention or treatment? And I remember this was a tremendous contested debate in global health before there was a recognition that this was not a dichotomous choice when it comes to a raging pandemic in parts of the world that didn't have access to treatment. And the debate was resolved, I think, by understanding that prevention and treatment are not mutually exclusive choices. And this is something that we saw once antiretrovirals became more widely available, that prevention was indeed significantly linked, and if not dependent to some extent, on the extent of treatment. So there's lots more to do, but I'll let Florian come in.
Thank you so much, Lisa. But you covered it so comprehensively. Yes, I agree. I come from the same story. I mean, growing into the HIV/AIDS pandemic and seeing the lack of access to treatment was my movement into the human rights and access to care arena. And to put it simply, we had a lot of discussions in Germany on how we would prioritize the access to vaccines. And I just imagine how it would have been if we said, well, there is no problem. Obviously, the rich people get first treated. And that is what we do on a global stage. Yeah, but tell it to the Canadians, tell it to the US people and say, well, what is the problem, Germans? The rich come first and then we see who can afford it. And as Tedros and others said, this is not, or Guterres for that matter, it's not only morally deeply wrong, it's also inefficient. And we have to think about the strategy, how best to address that. Yeah, but otherwise I agree. The question is how to move forward. Now the company today in the morning, I heard that BioNTech and Pfizer have agreed to set up a manufacturing facility in South Africa come next year. Right. But we have to deal with the problem now. And I do have some hope that we get some feedback in our panel how German policy will change potentially with the new government coming in.
Thanks, Florian. I see that our audience is listening, but we need to stimulate here that we get a few questions. It's a unique opportunity if you have Prof. Lisa and Dr. Florian here. So please go ahead in the chat. In the meantime, Lisa, I have a question really, because I'm very pragmatic. I'm the typical pragmatic person, right? We've seen now that you know, we had international health regulations in order to collaborate on anything that could cause, you know, sort of health risks in different countries cross-border in the updated version of 2005. But we've seen now in COVID-19 that we have, as one and only response, particularly in the wealthy country, to protect exclusively the population and national boundaries. And even worse, it's almost national responses. And when it comes to COVAX, there is, I think, only a complete failure. We had treaties already that should actually help us in order to overcome the situation that we are in. They didn't work. Now everybody is discussing pandemic treaties. Now this is the new thing, right? What is your hope and your stand on, can we ever address global health issues with equity as a topic or in mind and get it globally controlled, or let's say the actions being coordinated between countries, or whenever there's the risk, particularly for the wealthy countries, then they take the right of the wealthy for themselves and do first whatever they want to do?
I mean, all of that is very much the question. It's the question that underlies, I think, global health equity, and it certainly underlies the way we think about international law. When do countries comply with, sort of high moral aspirations, principled commitments to solidarity, to equity, and when do they not? And so, I mean, I think raising the question of the international health regulations and the extent to which those have been largely ignored in COVID, and the extent to which we're now looking at creating a new pandemic treaty. I mean, I think the question for those of us in global health, and certainly in the context of global health law, is whether it's at all possible to come up with any set of principles, no matter how legally binding, that countries will comply with. I mean, what we've seen in COVID, and here, sort of as a global health researcher, usually you're speaking to arcane knowledge that people have had to research over time, and you're bringing that information to audiences who may not know the issue. We're not in that situation in COVID. Every single one of us here, everyone in the audience, has lived through watching a pandemic unfold, watching what that impact is like in their lives, watching what policy looks like. And unfortunately, as you say, Olaf, what has guided policy decisions at the domestic and at the global level has not been anywhere near principled commitments to solidarity, to equity, to collaboration, to assistance. It's been a little bit like if we used an analogy that we were on the Titanic, it's not been sort of women and children first to the boats. It's been everybody trampling over everybody else to get to the boats. Fear is not a basis on which to run any type of system and the allocation of goods. And this is, I think, precisely why we're in the kind of situation we're in now, where global disparities are as they are when it comes to COVID vaccines. So when it comes to, and this I'm going to say as a human rights lawyer and as an international human rights law scholar, when it comes to human rights, treaties are only as good as the extent to which they are enforced. And absolutely, unquestionably, in HIV, in almost all human rights arenas, human rights protections become very meaningful, usually primarily when they are used by civil society, when they're used as mechanisms to challenge governments, to challenge private interests, to challenge what governments do domestically and what they do globally. We saw this very, very clearly in HIV. The political, corporate, commercial trade interests of powerful actors is not going to pay any attention to a country. A government is going to pay very little attention, if no attention, to its binding duties under international human rights law treaties and in its domestic constitutions, if it has actually more fundamental, what it sees as more fundamental economic interests. But that calculus changes when human rights can be used effectively to challenge governments and also to change public opinion. That's when governments start, when policymakers, when companies become much more amenable to changing their position, to shifting some of the power differentials, to limiting some of their rights. And, you know, Florian, I appreciate I didn't know about the Pfizer-BioNTech agreement, and it doesn't surprise me. There was the debate over the extent to which IP matters given the lack of manufacturing capacity. As we know, this has been the debate has been, well, what does IP don't matter because there isn't manufacturing capacity. And the New York Times had a fantastic article come out in the last 2 weeks, which delved into that question of manufacturing capacity and said, look, you know, there is actually capacity in 8 or 9 companies in various parts of the world that if the companies shared know-how, could be up and running and making at scale mRNA vaccines within 1 year. So this was a tremendous, I think, pushback against the argument that has prevailed, which has said, well, what do IP rights actually matter when there isn't manufacturing capacity? And here again, sort of the edifice of opposition is I think starting to shift in recognition that there is very little to balance the economic, whatever the perceived economic losses will be versus what the public interest or the public perception losses might be. So I'm going in a very long-winded way to answer your question, Olaf. But it matters. This is where I think human rights can be really, really effective, is in bringing pressure to bear on actors who are very entrenched in their political and economic interests, and doing that effectively in a way that advances equitable questions of equity, considerations of solidarity.
Mm-hmm. Thank you very much, Lisa. Although I must admit, it doesn't make me far more hopeful what you're saying, because I picked up, you said it so nicely, treaties are only as good as they can be enforced in one way or another, isn't it? And we simply don't have in health anything like international law or a court or anything else that would help us in order to then also seek enforcement if necessary. I'm personally not very much on the side that I like to enforce things. I think actually it should come voluntary, much nicer, but unfortunately it's not the case. Florian, any comments?
Yeah, thank you. I tend to agree. This is how we do. We have this discussion in our course, applying the rights-based approach in achieving health-related SDGs. We have this discussion all over again. But I tend to agree with Lisa's idea that the treaties, they can serve as a kind of a reference point, and they are useful in that matter. But they need to be translated. But we have seen in the case of HIV and the trial that was pending in South Africa that there is a chance of working with these kind of treatments and treaties and convenants. But it's not. Yeah, I mean, it still needs civil society, and we have to say again, we can learn from the HIV/AIDS experience, because without the civil society, treatment action campaign in South Africa, we would never ever reach where we are. And this is why I found this graph so useful to see, and Lisa's argument as well. You see, it hasn't harmed. Appreciating that these are very different diseases and the urgency is much higher, and maybe even the risk for the rich people, because one of the drivers in HIV definitely was the fear that this could spread, and so it was the case with Ebola. It could spread to the rich countries. It didn't do it in the same way as this is now affecting that. And of course, we have the discussion, maybe for once the younger African population is even better protected. So some people and colleagues from Africa argue in that way, but that doesn't make the case different. The availability must be, and the access must nevertheless be assured. I just wanted to add one argument that I always feel with the felt emphasis on inequity, with the fact that we have now the booster campaign in the rich countries. Yes, it is true that this skews the curve even worse. On the other hand, I would just say, if it was medically the right thing to do, I wouldn't argue for a suboptimal treatment in one setting. I mean, that is as if we said, now, well, these days 2 drug regimens may come up in HIV, but to say, well, better you get 1 drug than nothing, so better 1 shot than nothing. So we still need to look at the fact what is needed. And if the experience, let's say from Israel and other countries, show that this is needed, we have even more pressure to say, okay, get it out there and get people, but get it in the right evidence-based dose.
Very nice. Thank you, Florian. Thank you, Lisa. I just want to contribute. We're getting the first questions coming to that in a second. You know, I was in February this year in some initiative on pandemic preparedness, and there was a colleague from the US actually, and we were discussing exactly the question of equity and distribution. And Lisa, using your example of a Titanic, I actually would like to say, no, it's always first class first, right? Or the second and third class is not going to get off the boat there, no? And that is what we're seeing continuously. Now, it was really interesting because there, the colleague, I was, of course, driving the equity and global health argument, where we can equally say, if we don't start to protect the vulnerable, we are going to see death in countries which are completely unnecessary globally. And if we don't start to vaccinate everyone at some stage, then the entire thing is not going to be controllable ever. And she was actually saying, no, you're completely wrong, the colleague says. And that is sort of showing exactly where the differences lie. She says, we in the wealthy countries, we need to protect ourselves first and put our masks on before we can go out and help the others. And I thought it was really so interesting, this word help in there, because it's this typical argument of we are not working together, but we are sort of in an aid idea or charity. We are sort of improving the lives of the poor when we can, right? And that clearly shows, in my view, the differences in view of things. However, first question, and to the audience, more questions, please, if you can. Sophie Hilda Lemupa Makariov is actually asking, what about the right of someone to choose to be vaccinated or not? Now, this, of course, is now predominantly for the countries where vaccination is available. But the question then says, what becomes about the rights of those who don't want to be vaccinated? Very, very up-to-date question, where I am at the moment in Heidelberg and Baden-Württemberg, because they are now discussing that with, again, rising infection rates, weekly incidences mostly, if the rights of those who are not vaccinated or cured or are going to be curtailed. Lisa, perhaps you first.
Yeah, absolutely. So Sophie, thank you for your question. I think that gets at some very fundamental debates around the appropriateness of vaccination mandates, and also the balance of rights, of individual rights and imperatives of public health. So I'll say this, that I think there are the question of vaccine hesitancy, you know, people who are hesitant, not necessarily anti-vaccination in general, but hesitant about this vaccine in particular. I think it is important that there is an extent of national translation of science appropriately to to quell people's fears. I think we know that there are many communities and populations in various countries that have legitimate reason to distrust medical science, communities who have experienced fairly harmful practices in the past from medicine. So I think ensuring appropriate information and education to all about the efficacy, the safety, the science behind these vaccines is absolutely fundamental. And from a human rights perspective, that is fundamental. It is a core obligation of states to ensure that everybody receives access to health information. But I think where this debate often kind of goes a little bit wrong or a little bit skew is in seeing the individual rights of people as to not want to get vaccinated as somehow outweighing the public health imperatives of dealing with a deadly pandemic. Now, frequently, if you are coming at this from the perspective of a lack of information, a lack of a little bit of uncertainty, I think that you can recognize why that might not be a choice that you were willing to make about getting vaccinated. But I think that what we have seen in countries is that there are very different approaches that countries take to the question of how you ensure that people get vaccinated. Some places, countries mandatory vaccination for others. Others just simply encourage vaccination and create incentives and disincentives to not get vaccinated. Now, from a rights perspective, because Sophie, I think this is the question that you're really asking when you ask what becomes the rights of those not yet willing to be vaccinated. I think the balance of rights here really. I think I don't live in a country where people are forced. There is no law forcing people to get vaccinated, but there are certainly, in the context of a vaccine that has high efficacy and good safety, and where we're seeing that it is transforming the pandemic, I think it's absolutely appropriate for workplaces to be able to implement mandates to say, look, you can't come into work if you're not vaccinated because it puts other people at risk. And to say that there are restrictions in terms of what you can do out in the world, whether you can go into a restaurant, whether you can get onto a plane. Now, the bigger equity question there comes if you want to get vaccinated and you can't, which is sort of the disparities that I was pointing to earlier there. I think we have really, really fundamental rights questions. But when it comes to the balance of individual rights and the pursuit of public health, international law is actually very clear on this, that you can balance you can restrict individual rights in service of public health, so long as those restrictions are time-bound, necessary, and in that they're established by science to be, if you restrict the right, it's going to serve a public health goal, and it's proportionate. So it's actually the restriction that you're imposing is not out of all proportion to the goal that you're trying to meet. And I think in the context of a global pandemic, the public health imperatives of achieving some measure of containment of COVID certainly suggest that the public health imperatives certainly justify certain extents of restrictions of individual rights when it comes to vaccinations.
Thanks, Lisa, and quite clear on that, and I fully agree. I must admit, in the context of this particular epidemic and pandemic, of course, one also needs to continuously try to understand the other side. And I think, for many, particularly young people, the risk of severe disease is actually not so high, and very often there are fears. No? It's very difficult to argue against that always, but very interesting question. Florian, do you want to contribute or?
I think, thanks, I widely agree. I mean, we can look it up. It was back in 1980s, I think, the Syracuse principles that have Lisa implicitly referred to, so several times. I would rather leave the space for some questions. I think I saw some Lisa, can you help us and bring them up? I think
I can do that, Florian, don't worry. Because Lisa is doing a perfect Lisa Henning here for all the audience. We have two Lisas here.
Okay.
So Lisa Henning, who is collecting the questions for us. And perhaps we go briefly back to the question that Astrid says about IHR and how can we get more teeth, I like the expression, for implementation. But perhaps we want to expand on that one more time. And I'm going to challenge Lisa and Florian here. Because you know what, I'm actually normally a very positive person. I think for some sort of a system where all countries agree that we are going to stick to some rules of collaboration for health, and that there is a system of repercussion if you don't do as a country, an international health court, if you wish, we are never going to go there. What do you think? What are the other options?
So thank you, Olaf. That was a fantastic framing for Astrid's question. And thank you, Astrid, for your question. I, along with every other researcher that I know that works in this broader area of global health law, since March 2020, we've been very, and certainly before, but very much engaged in the question of how do we make the international health regulations more effective? Because like Olaf, I too, as somebody who'd been always extremely optimistic, I'm a human rights lawyer, I'm a human rights scholar. I obviously believe fundamentally in the value and the legitimacy and the importance of commitments like human rights. I'd say in the last 6 years that optimism has been absolutely dashed, and certainly during COVID, seeing the extent to which the IHR has been simply ignored by countries, sort of in this, sort of running for the lifeboats, hoarding vaccines, the same way, sort of, I don't know what it was like in your country, but in mine, when COVID hit, everybody, you couldn't find toilet paper or canned goods and that has been the approach, so a very significant focus has been, well, here we have this sort of high-minded effort in the international health regulations. Really, this was the supposed to be the prescription and the blueprint for what countries should do the next time we had a pandemic, and it just got ignored. So the question very much is, well, what do we do? Can we give the IHR more teeth? Is it possible? Is the solution to revise the IHR? Is the solution to create, as Olaf says, an international health court, which I agree, we may be a little bit far off from that. Is the solution to have a pandemic treaty, which, and so the International Health Court, Olaf, you and I can have a lovely discussion about this another time, but the strengthening of the IHR, revising the IHR, creating a new pandemic treaty, these are the options that are on the table. And the question of whether to revise the IHR, we've watched the institutions go back and forth over the last 2 years. We've had the committee at the WHO, which oversees the IHR, first say we shouldn't revise it. We should look to a pandemic treaty. Now they've reversed course and they said we should revise it, and we should also look at the pandemic treaty. We're not actually entirely sure at this stage that there even will be a pandemic treaty. So how do we give these things teeth? Certainly, so I think this comes back to the underlying question that sort of we keep getting at, which is how do you make these rights and these treaties and these principles have teeth? How do you make them enforceable? And the very clear lesson that we can take from HIV, from human rights challenges in general, is that the only way to do that is to pressure powerful actors where it matters to them, and where it can matter is in public perception for both elected officials, for elected policymakers, and in public perception for companies, because public perception translates directly into dollar signs for corporate entities. So in international law, there is this recognition that, between, the reason that governments will comply with international law, and contrary to the discussion that we've been having, the recognition is actually that although the enforcements are actually weak at the international level for many treaties, governments comply with international law more frequently than they don't. And the reason for that really is a mix between being morally persuaded of the legitimacy of those principles, having that high-minded commitment to the principles, and being coerced. And it's a mixture. It's not one or the other. It's a mixture of things that matter. So there's no question on these things. It is fundamentally important for civil society to be playing a part, for researchers in global health to be playing a part. The extent to which empirical, rigorous, peer-reviewed research and can play a role in supporting some of the arguments that are brought to bear, it cannot be overstated. It plays a really important role. So that, I think, so Astrid, so I'm doing a very long way around to say the way that these things can get more teeth, it has to come from both perspectives. We need more teeth at the international level in terms of penalties, institutional mechanisms that can enforce. We need more pushback from the bottom to put the teeth in from that side.
Thank you, Lisa. Very interesting answer. If we can actually get more teeth, and I think history, particularly from HIV and AIDS, actually showed us that sort of the off-patent production in countries that then early happened for poorer markets where you cannot, sort of have so much money, where there's not so much money available, plus financing mechanism like the Global Fund mechanism, is if this would be prospectively in place, right, then I would be happy already. Bearing in mind that the first class syndrome from the Titanic, that the first class saves itself first in their classes. So we were probably not going to overcome that. I would like to see a pandemic treaty. Before we have 10 minutes still. We have a bit of a surveillance question, comes in a second, but Astrid was actually continuing with an interesting question that fits into what we're discussing here. And she's actually asking exactly about this off-patent, the waiver, if it's a way to go, and how can we convince the rich countries in order to do that. On top of that, she says, never forget that a lot of basic science that leads to new products is actually financed by governments and not by companies, right? So the argument why you cannot produce, sort of in poorer countries is actually almost not there, because the basic science, sort of is very often financed by the community, by governments altogether, and not by the companies. How can we get a waiver through if we want to do that?
So Astrid, thank you. Your point is excellent and very well taken. I mean, I think this is another very significant piece of the broader puzzle, and something that became very clear in context of HIV and in the access to medicines research and policy that followed it. The recognition that the innovation arguments hold very little weight when it comes to diseases in low and middle income countries, and also to markets in low and middle income countries. The recognition that the markets there were so small as to not, as Olaf would know very well from his work, certainly it provided no incentive for innovation for the diseases that occurred there, but even where it was in relation to diseases that were within both parts of the world, in the rich world and in the poor world, like HIV, if there was use of weakening of IPR in those countries, it had absolutely no impact on wealthy country profits. So the innovation argument when it comes to low middle income countries is extremely flawed, and I think there's an absolute metric ton, of recognition in policy, in research to this extent at this stage. I feel like that debate is really over in some respects, but the question Astrid asked, I think, is very, also really how do we get governments to support the TRIPS waiver? and asking them to governments to set down clear parameters for industry, Astrid said, seems to be a weak point. And well, so here we get right back into the argument, the discussion we've been having, which is, when do governments push back against pharmaceutical companies or other industries that obviously they look to for a significant extent of economic stimulus in their countries? When do they do that? And clearly, and sorry if I'm sounding one note here, but I think the lessons of HIV are so significant in this present moment that it's very difficult to look at what's happening now without going back again and again to what happened in HIV and saying, when you can bring pressure to bear on elected officials that makes them feel like, well, if I don't do this, I'm going to look bad and it might impact on my electability, that's when they're going to be willing potentially to put some restriction or some regulation on industry. Potentially, we saw that during HIV. We're seeing that we may see some of that now. I mean, I was absolutely astounded when President Biden at a point said that he would be supportive of a TRIPS waiver. This is not anything I ever thought I would ever see from a US president, because the US is the locus point of the promotion and enforcement of very, very far stricter intellectual property rights than are even contained in the TRIPS agreement. Now, the fact that it wasn't followed through, it's obviously, you can say, well, this is just rhetoric. But the fact that even the rhetoric is changing is, I think, a really excellent indication that the debate has shifted. I mean, the debate in international, sort of, if we go back to all of the arguments that I presented, the debate now is not, should we use TRIPS flexibilities or shouldn't we use TRIPS flexibilities, which is where we were with HIV. It's TRIPS flexibilities are the answer, not lifting intellectual property rights. Now, it sounds like a very small, minor point, but I don't think that it is. I mean, I'll come sort of to the realist perspective and say, not enough has changed despite the successes of HIV to think that we were as successful as we'd hoped. But that is, again, it has to come from pressure and it has to come from the ground up. We have to be pushing our elected officials to do differently. We, within each of our countries, need to be approaching our political representatives, our members of parliament, and pushing them to be pushing the government to be doing differently. This is how we can achieve change.
Thanks a lot, Lisa. I think in view of time, we only have a few minutes. Florian, unless you wanted to comment, because we have one more very quick question, which is probably going to go very much into your direction and surveillance, but let's see, or you wanted to comment urgently on the waiver question, Florian.
Just quickly to say, I think one strategy certainly is we are not going to do that on a moral basis. It must be kind of a vested self-interest as well. And even our Ministry of International Cooperation says, guys, we are not going to control this pandemic unless we get people vaccinated all over the globe. So we may or may not like that, but the vested self-interest it plays also part in that. So we need to use different veins and avenues to reach that. That is pressure on the electorate, because on your argument, I mean, in Germany, you may not be very popular with the thing, we have to invest more into COVAX, etc. So you have to play it very well and in different directions. That was my comment, but
yeah, thank you, Florian. Before we wrap up, a very short question, and to either Florian or Lisa who would like to contribute. Hanan Fadi Mohammed Nohan from Yemen probably is asking, exactly in the context of Yemen, that a lot of surveillance is an issue for COVID-19 data, reliability of data, of tests are being done, etc. There's an equity element in here in the context, because we have surveillance in the wealthy countries extremely well developed, like all other health systems, not to the poorer countries. What can we do in order to evaluate the situation of COVID-19 in the poorer countries?
Well, I mean, I guess I'll answer this from a human rights perspective. Yeah. And thank you, Hanan, for your question. I mean, I think there is no way to deal with a problem that we don't acknowledge as a problem and that we don't measure. And this is fundamental in the right to health. The responsibility of governments is to ensure appropriate information about the health threats within their community so that they can make appropriate policy, implement appropriate treatment. So from a human rights perspective, what Hanan is describing is an absolutely fundamental human rights issue. If COVID is not being appropriately measured, this is a violation of that country's human rights duties.
Absolutely. Florian?
Yeah, only to assure you, Hanan, Germany is not necessarily much better, but I agree. I mean, Lisa pointed out to say she was focusing on the vaccine, but of course there are other equity issues in the COVID pandemic, and access to diagnostics is there. And again, even if you get tired, we learned the lessons from HIV health system strengthening, and reporting is there. But I know Yemen didn't do very bad in terms of even in the cholera situation. So I mean, it is as well as the vaccine aspect, an equity and human rights issue, and it should be advocated in the same manner, and we should not limit us to access to drugs and vaccines.
I would say it is 1 o'clock. Our time is up. We are all doing electronic exercises here. That means I think we need to stick to the time, so that people get their breaks. Let me firstly say thank you to the audience and the very interesting question, facilitating our discussion here, the three of us. That was absolutely brilliant. I hope you enjoyed as well. Apologies for the technical hiccup earlier, a couple of minutes missing, but at least we got here. Let me say thank you to Lisa, not only for getting up at a ghastly hour, and I hope you can go back, sort of to have some coffee or tea, and a bit of normal morning exercise, but particularly for the excellent presentation, which is really an eye-opener. I think looking at health from an equity point of view is an eye-opener anyway, but in this particular context of COVID-19, it is not only an eye-opener, it's frightening. Thank you for that. Florian, thanks as always for your support and your clearly, sort of experience and work over so many years in global health, where you contribute to the equity discussion always with very nice examples coming out of practice and academia. Thanks for that. I'm taking out the following, if I may, and Lisa and Florian, correct me if I'm wrong. Firstly, I think COVID-19 shows us clearly again that equity is a big issue and continues to be an issue. Equity, particularly in the context of vaccine distribution, which is the one and only way out of the particular situation that we have globally, in my view. I'm shocked to see over years that with the experience we had, we were not proactively better in our response in order to have a global response. I would like to see from here a pandemic treaty developing, and the discussion is clearly out of there, or anything similar that ensures that particularly distribution of new medical knowledge, diagnostics, vaccine, whatever is there, can go quicker using the vehicles we know from the HIV and AIDS debate. And if this is going to develop out of this COVID-19 debate, then I said, perhaps we are going to be lucky, because at least it is not a pandemic that is extremely dangerous with high case fatality rate and high mortality, because at least with this one, we are preparing for the next one, which may be much worse, in order to have a better response. Would you completely disagree, Florian or Lisa, or shall we let the audience go?
Thank you for that, and thank you for your nice words. And I'm grateful that you took up the task also to guide us through this, Olaf. Thanks. I have nothing to add. I mean, of course, we can debate and discuss hours, but for now, I think I'm fine.
And same here. I just want to thank both Olaf and Florian and the audience, and also all of the wonderful people who helped in the background for making this such a wonderful discussion. I thoroughly enjoyed it and I really appreciate it.
So lunch break, everyone. Morning break for you, Lisa. Talk to you soon. Bye-bye.
Okay.
Bye-bye, everyone.